Good morning, everyone. Firstly, I'd like to thank the organising committee for the offer to come and speak to you here. I had met a few of them in Bucharest whenever ASGP were running a conference there. So this will be, for some people, maybe they have seen it before, but it's a look, it's a journey, it's quite a broad journey of where I come from as President of the Commonwealth Pharmacists Association, which I know has got no relevance to people in Greece, but it does cover quite a bit of the sort of the landmass of the world as we speak, and there's a number of things we can learn from global issues, bring them down to national issues and bring them down to local issues. So what I really would like just to talk about are just some of these, what are the big issues which are facing us globally, but then bring those down to things locally and relate them specifically to the area of self-care and how self-care is changing. So we will then look at those medicines which we use on a regular basis in managing self-care, but then looking at what needs to maybe change to try and broaden it out and to begin to look at the long-term conditions, which are really the challenges for the future. And I'll touch just a little bit on that. So just to give you an overview, first of all, of the Commonwealth, and that's the British Commonwealth as we know it. It does cover about a quarter of the world's landmass. It involves about 53 countries and has a population of around 2.3 billion, 50% of which is under 25. But it does have some significant challenges in terms of the global issues of HIV/AIDS and also infant mortality. But one of the things which is actually growing and one of the things which is becoming a big challenge is the issue of what we call non-communicable diseases or long-term conditions. There are more people now dying, even in Africa, from long-term conditions prematurely than from infectious diseases. So those people suffering from cardiovascular disease, respiratory disease and diabetes is now overtaking those who are dying from infectious diseases such as AIDS and malaria and TB. So the role of the Commonwealth Pharmacists Association is really to empower pharmacists to improve the health and well-being of the citizens of the Commonwealth. So just to give you a few bigger picture goals which have been looked at, we are well aware of, everyone in the room may well be well aware of the Millennium Development Goals which were set by the WHO back in 2000 and trying to look at issues which were of global concern. Three of those things which were health related, and that was the maternal health and also reducing child mortality, and the issue then of AIDS, TB, malaria and infectious diseases. That has been broadly successful but not completely successful. There's some of those, in terms of those health issues, we have reached probably 50% improvement, but certainly hasn't, in some areas maybe 70–80%, others not so much, depending on the country, but generally speaking about 50% improvement, which is still a massive improvement, but there's still some way to go. But as I said, the other issues are long-term conditions which are now beginning to overtake. The deaths from, premature deaths from disease is now becoming very prevalent. The other issue which is being addressed at the moment is this whole issue of universal health coverage. And these may seem very big issues, but I think they do sort of bring the issues together, because when we talk about universal health coverage and the model of healthcare, it has a significant impact in terms of how people access their health, how they access their medicines, how they access their overall health care. Whether it's paid through insurance or whether it's paid through taxation is a major issue. One statistic coming from the Commonwealth that I was aware of or became aware of, for example, in India, which has got a huge population, but there's 40 million people a year go into poverty from having to buy their medicines. That's 40 million people per year go into poverty from having to buy their medicines. That's 2/3 of the population of the UK every year going into poverty from having to buy medicines. There's no universal health coverage in India, but it is something they're looking at to try and address that issue. Another issue, or another statistic which is I find quite significant, in Bangladesh they have 150,000 drugstores, but in that sector they have 12 graduate pharmacists, because most graduate pharmacists go into industry. They have 20,000 diploma pharmacists, who are the pharmacists who would have a lower status of a degree, but they would have some basic understanding. of pharmacy and the pharmaceutical issues. But that still leaves 130,000 pharmacies or drugstores selling medication with the equivalent of a certificate, which in the UK could be the certificate that somebody would have for doing a cleaning job. It's an NVQ. An NVQ is just a National Vocational Training Certificate. Now, to do that, we have them in the UK for selling medicines and being a support to the pharmacy, to the pharmacists and to others in the sector. But in Bangladesh, they are now selling vast amounts of medicines without any real training. Those are the challenges. So if we take those challenges and then begin to look at non-communicable diseases, look at self-care and what the vision is for WHO in terms of that. And they're looking at a world free of the burden of non-communicable diseases. So what are the issues which can actually try and prevent these conditions from happening? But it also goes on to say that it needs a multi-sectorial collaboration. It needs cooperation at national, regional and global levels, so populations reach the highest attainable standards of health and productivity at every age, and that these diseases are no longer a barrier to well-being. So what are the major issues? There's a number of issues which, in terms of self-care, and let's say long-term conditions, non-communicable diseases, we can look at these sort of almost as a whole. Four main things which we know that everybody can do in terms of managing their own health. That's look at their tobacco, smokers, try and help people stop smoking, try and get people to take up some physical activity, look at their diet, and then avoid the harmful use, the misuse of alcohol. Those are things which, as a message, certainly from pharmacies, is a health message from anybody, should be being supported on a day-to-day basis. But then when somebody does have a condition which needs to be managed, medicines become a very key part of that, and how we access medicines. Now at the moment in the UK we have three categories. That's prescription only, then we have the pharmacy only, which are medicines which are available from the pharmacy, but also can be available on prescription, and we also GSL, which are basically medicines purchased anywhere. We have had a movement in terms of trying to improve self-care with more medicines moving to be available to the pharmacy only and then into OTC. But I think some things have worked and some things haven't worked, and I just want to sort of bring you through a sort of my own personal view of what has worked and what hasn't worked, and then look at the potential for a vision for the future. So just factors to consider what does work in terms of medicines which are purchasable over the counter. I think they have to be, first of all, affordable. I think that was mentioned earlier. If price gets too expensive, people will not purchase the medicines. They have to be something which work and people believe work. Whether it's not they believe it works, and for them it does, whether there's any evidence behind it, there's quite a strong placebo effect in a lot of medicines. But if people believe it's working and it's doing them good, it's not doing them any harm, then that's something to be considered. But we must make sure that the quality is assured. And going back to my Commonwealth perspective, another one of the issues which we've talked about in some of our conferences is the whole issue of counterfeit medicines and medicines with poor quality. We reckon that 1% of medicines in the developed world can be counterfeit, which does reach then about 10%, sort of if you look at a global issue. And the reason for the disparity of the global issue and the developed world is that it can be about a third of medicines in the developing world can be counterfeit. And counterfeit medicines can have three main aspects to them. They can be medicines which have no active ingredient. They have less than what they say they're going to be. They can less of an amount of an ingredient than they say on the packet. So some medicines can be quite expensive. So rather than charging the full amount, some manufacturers in developing countries will put in half of the medicine and then charge half the amount. One of the biggest issues which is leading to resistance to anti-malarial medication is that medicines for malaria are being sold with 50% of the active ingredient. And the third one is that some of the medicines can actually have toxins in them which can be toxic. So that is the quality issue. We don't have an issue really in Europe with quality. But even at that, the European Commission have brought in the FMD directive, and we know that there's going to be tracking and tracing of all medicines from 2019, and that is to ensure that our quality is maintained. But also, which has been, George has also mentioned, this whole thing of the education of both prescribers and consumers. And I think this is the whole area of self-care, where we, patients and the public and population and citizens all need to be educated as to what to expect in terms of medicines, what to expect in terms of what they can do in terms of self-care. And if that's all brought together as an educational package, I think that can certainly give a good building block then for when medicines are introduced. So what then does work for medicines which are switching, or for working, medicines which people buy over their patients buy over the counter? Mostly at this moment in time, it's for self-limiting conditions. Short self-limiting conditions can be colds, flus, it can be acute pain, it can be episodes of diarrhea, constipation, short episodes of fungal infections. All things which within 5 to 10 days are self-managed and work well, they sell well in terms of people have trust in the products and use them. What doesn't seem to work are those conditions which are medicines are required for longer term conditions. And why is that? I believe that that's partly because medicines which are used in longer term, people like to have, there's a management issue, there's an issue about how do I just keep taking this medicine day in, day out and never be reviewed, never be checked. And I think when we look at some of the ones which worked and some of the ones which didn't work, we may find out that it's around monitoring or management of it. But it's also price sensitive. If people are going to have to buy a medication on an ongoing basis, day in, day out, week in, week out, month in, month out, this is an ongoing issue. If the price is too high, then if it's available through the national health system, it's more likely that they're going to get it through the national health system. So just to give you some examples which I feel have worked, certainly in my pharmacies, which have sold well. These are just some examples: the loperamide, ibuprofen, even the ranitidine, hydrocortisone cream, the EHC, levonorgestrel, all things which are self-limiting and can be treated quite quickly, and with access to medicines, it is fine. But then when we look at the simvastatin, pantoprazole, tamsulosin, why did those things not sell? And I believe it comes down to this issue of being a longer-term condition. Certainly simvastatin as a product which came on the market, it was 10 milligrams of simvastatin, and then you got a contradiction. Well, at that time, 10 milligrams simvastatin was used quite a lot for the management of cholesterol levels, but then it was beginning to change, and as the stronger statins came on board, then doctors sort of felt, 10 milligrams is not going to do any good. So there was a sort of a signal to sort of say, look, it wasn't really worth taking because it wasn't going to be a significant benefit. But I think also there's that sort of the attitude or the understanding of what the medication was doing. It's about education of the patient, the monitoring, were we actually going to be getting an effect, a beneficial effect? So when people started taking the medication, were we able to measure a benefit so that they could then be assured, yes, this was bringing benefit? Did they have the right information? But again, the ongoing price, I think in the UK it was around £20 per month. Now, if somebody's getting paying £20 per month, they go to the GP. At that particular time, they could get 2-3 months' supply, maybe on prescription for £5. And if you got your medication free, which certainly from in my part of the UK, 95% of patients were getting their medications free of charge. So there's a significant cost implication. So what's going to work if you want to try and broaden self-care from the acute self-limiting conditions, and then begin to address some of the other sort of longer-term conditions? We need to be looking at service development, practice change, and what I will talk just about, the potential for a model of service, because I think we really need to look at a new model of service. We need meaningful involvement just with all the stakeholders as to how the communication channels are going to work, how the cost is going to impact on individual people and families. Also, that sort of the infrastructure, because managing self-care and taking medication is fine, but when we talk then about monitoring, how are we actually going to manage the monitoring side of that? And then there is always going to be that there's no point in putting a product on the market if nobody knows about it. I'm sure you're all well aware of that. So how do we advertise that, and how do we get all the figures to balance up? So the challenges which we face globally, but also nationally, in Greece, in the UK, in any country that we're actually looking at, is just, these are all the same across, certainly across Europe. Aging population, increasing population on long-term conditions. And if we look at the room and take the room as an example here, the number of people here, how many people would suffer from either hypertension, respiratory disease with a bit of asthma, or potentially type 2 diabetes, and how are those things managed? How do you manage those? And the numbers of journeys to GPs for management of those conditions. But again, we've got then multiple morbidities, the frail elderly, also that increased expectation that patients have now that health systems will just look after me. And it's just that sense that we need to actually be taking more control of our own condition. So that there's the pressure on the primary care systems, the healthcare systems, which go right through from primary care to secondary care and into tertiary care. And if the access to the health system in each of our countries is set at a bar where everybody sees the GP, the doctor, the medical practitioner for minor conditions, self-limiting conditions, or conditions which can be self-managed, it puts an extreme pressure onto the system. And we're seeing that certainly in the UK now, where getting access to doctors is becoming much more difficult. So the questions are really asking is, can community pharmacy use its resource, or is community pharmacy underused, and can we begin to see pharmacy, which is based in the community, help manage some of these conditions? Have we the potential to fill this gap and reduce the pressure on the health systems? And also, have we the skills to move up and begin to support patients rather than be just supplying medication? We become much more patient-facing. So I want to just present, a concept, and this is a concept which I, along with the GP that I worked with in my own hometown, we began to look at how we could manage patients in the community pharmacy setting. But to give you a little background on that, first of all, in the UK we had a change of legislation which allowed non-medical prescribers to begin to prescribe medications which were normally prescription only. And that was back in 1999, and we had two new categories of prescribers: an independent prescriber and a dependent prescriber. The independent prescriber could take on the area of diagnosis, and then the dependent prescriber could be prescribing under the auspices of somebody who was an independent prescriber. But the two conditions which were really laid down was the clinician should have access to a medical record. So there's very difficult to start and prescribe medications for patients if they don't have access to a record of a person's diagnostic history, their allergies, their medication that they're actually taking, and to have a picture of that person's health record. But also that the supply and the diagnosis, or the supply and the initial prescribing, should be kept separate. So we said, what had happened was that I was trained as an independent prescriber by my local GP. I'd been running clinics in the GP surgery, access to the records, and basically patients who had been diagnosed with hypertension, I was managing them. The GP would say, look, I want you to manage this group of patients, and there was clinics would be set up by the practice. People would be coming in, and I would be carrying out the hypertensive review, looking at their history, looking at their medication, and then taking blood pressures and adjusting medication, stopping medication, but also annotating the record with any of those outcomes. So what was required then, in the discussions, we sort of felt, what about the people who can't come during the week, who are working, who don't attend the surgery? Could we run something like this in the pharmacy on a Saturday morning? And we looked at it and we sort of felt, well, there's a few things we need if we're going to do that. We need certainly a communication tool, we need the information, and we need an integration. One thing follows from the other. So what we got was really a laptop which was designated for the GP practice, which meant they could work at home and do some work at home on some of their clinical work. We were able to take the laptop, bring it into the consulting room in the pharmacy, and then set up a link directly into the NHS net, which brought me in then to the server in the GP practice, which gave me access to a patient's records. So basically we set up, it was last year, January, February, March last year, we set up to have a clinic each Saturday morning. There was 3 pharmacists involved. There was myself. I have a colleague who does respiratory work. He does COP diagnosis and asthma reviews, and a third pharmacist who was a pharmacist who worked in a GP practice, and then she took on and did some clinical work as well. And we did the clinics over hypertension and asthma. They were basically built on the same premise of what the work was in the GP practice. And that was just, the whole idea of it was really to do a blood pressure assessment or an asthma assessment. We had the lab results there. We'd be able to interpret those. We'd be able to do an assessment if needed be, being a cardiovascular risk, checking techniques, checking the oxygen sats, just basically doing everything which was done in the surgery during the week. We had the private consultation room, but we also had the full remote access to the clinical system, and then everything which was carried out was annotated, and the GP, if he or she wanted to, it was there on the system and it could be viewed at any time. So what was the outcome of it? This was just really a concept which we had, and we wanted to see how it would go. So this is only over 11 clinics. We saw a small number of people, 74 people. Again, numbers are small, but it's not about necessarily the changes, it's the concept itself. I think just seeing, could pharmacists do it? And the other part of that question is, would patients and would the public accept it? So we say we were able to change some doses, some medication was discontinued. Compliance issues was always one which was part of our consultation, and learning how to discuss this with patients, find out what the reasons were why they weren't taking some of the medication, why they decided to take it the way they wanted to take. So there was a number of issues around compliance addressed. But again, medication reviews and lifestyle advice was given for the majority of those patients who attended. So in terms of those people who were attending who didn't have their blood pressure to target, and there was 18 of them at the start, we were able to get, and bearing in mind this is only a very short period of time, there was 3 months, we were able to get 7 of those down to target, which still left another 10, which would be then followed up again in the surgery after the pilot sort of finished. We did get an average drop in blood pressure of 14/8, and the number of patients then were educated on their asthma. But again, it's really just a concept. This was all carried out in the small consultation room in the pharmacy. But I think this is the part which I find very interesting, and it is the patient's perspective of it, because this is something which they had never been involved in before, and they'd always seen either the nurse or the doctor. And I'm not sure what it's like in Greece, but I know back home the message has always been, when people have got health issues, is always go and see your doctor, go and see your nurse. But the satisfaction rate was extremely high. And if you look at the bottom one, on the scale of 1 to 10, how would you rate your overall experience? I don't know about you in the room, but I'm very loath to give anything 10 out of 10 as a score, because we usually say it can always be improved somewhere or other. But 91% of people said they scored this 10 out of 10. And they said it benefited, it was better, easier for them to come and see on a Saturday morning and have the consultation. They had the same trust and the same level of trust in the care of the pharmacist than they did in the other medical practitioner. So the satisfaction was actually very good and very high, which gave me a lot of hope that as we move down to this whole area of beginning to see self-care in the bigger field of being more than just self-limiting conditions, but more long-term conditions, pharmacy and community pharmacy in particular, in this particular case, is able to help fill this gap. The GP feedback on it was very positive, because they felt it really made a difference to the patients being able to access their health care. And the patients' comments, basically again, they just found it was very helpful, and just they felt it was more personalised, because they're coming into the pharmacy for their medicines anyway. And this was really just about having a discussion, sitting down, having a discussion, being able to monitor, reassure patients that the medication that they're taking is either doing the job it's supposed to be doing, or if there's a need to be changed, it could be changed. So they found it very reassuring, and wanted it to continue. Unfortunately, we haven't been able to continue because funding as such wasn't available, and we're still back to the challenges again, because what we have as a challenge, if we want to begin to move and change the perception of how self-care is managed, that we need to have proper communication, we need to have information if we're going to do the job properly, but we also need to be integrated. So in one sense, integration brings the other two things with it. So it's about seeing the pharmacy integrated into the healthcare system and not sitting outside that. So there is a need to getting momentum, and how we get momentum is just about trying to bring all the stakeholders together, see the benefit of it. But this being a fairly major shift, it doesn't happen immediately. There are barriers to it. It's certainly in Northern Ireland, where I am, the barriers are really sort of IT issues, because at the moment we can't get access to the ECR, which is the electronic care record, where we can actually have a discussion with have viewing of the patient's record. So unless we can view a patient's record, and there are some who would say pharmacists shouldn't have an access to that record, and others are saying we should have. But then it's really about the model of service. So is the model of service, and this is just one example of a model of service, and as an industry looking at self-care, looking at how we manage OTC medicines, how people access OTC medicines, this is just one area or one example of how we can begin to look at it. Because I've been talking to colleagues and to medical practitioners and to people within the service, how do we actually change the model of service? We're so stuck in the sense that pharmacies supply medicines and GPs prescribe medicines. And I think we really need to get beyond that and begin to use the skills of our professionals to the best of their ability. Because the service and the expectations within all our health systems is just enormous. And unless we begin to change it, then we will continue to be snowed under, and the service level will continue to decrease. So just finally, I want to leave you just with one comment from a chief pharmacist in Scotland, which he basically said pharmacists need to get out of the dispensary, put their knowledge of medicines into practice, and we have to base our practice on patient care. And if anybody wants to, the paper was published in the Journal of Medicines. The Journal of Journal of Optimization of Medicines. It's organised by Pharmacy Management, but you can have a look at it there. But that's what I've got to say. I'm certainly happy to take any questions, or if you want to talk to me later on during the day, I'm very happy to do that. Thank you very much indeed.